Medicolegal Issues in Critical Care. It's chapter 19, page number 229 in your medical management textbook. So when it comes to critical care or ICU care, it's a very complex and very intensive ward, okay, in which there are a lot of opportunities for the caretakers, physicians, nurses, any other paramedicals. Okay, they have a lot of opportunity for lapses in monitoring the effect of any interventions or in medications. Okay, usually 78% of the medical legal issues arise from medication errors, even in ICU. Okay, but it's a very complex and very intense environment. Any lapses, chances of a lapse in care which can lead to medical legal issues is quite high in ICU department. Okay, so when it comes to the legal procedures in cases of medical negligence, there are three main forms of legal procedures which we follow in the courtroom. So first is the Fry standard, okay, in which what happens is that you are focusing more on scientific evidence. Okay, the court, the judges, they will focus more on the scientific evidence in whatever field of medicine was being practiced in the ICU. Okay, so they will the court will disregard any unscientific or optimal scientific basis. The court will only go for a complete scientific breakdown of the case, cause and effect. Okay, evidence based practice, what it says and what was seen here in this case. So that is Fryer standard. It is completely scientific basis. Court will only go by the scientific basis. Second is the Daubert standard. It is a mix of scientific basis of the case as well as expert opinion. Okay, Daubert standard, the difference between Fry and Daubert is that in Daubert standard, experts are also invited to review this case from their expert evidence. This could be other doctors, other clinical practitioners who are well versed in that particular field where the case have arisen. Okay, so that is a Daubert standard. So in Fry standard, it is completely based on scientific readings, scientific interventions, what the science says, what is evidence based. That is what Fry standard is. But Daubert, it is science based. Along with that, an expert committee is invited to judge the case as well. Okay, next we have the causation. Causation means what was the physician's action? Was the harm that has been caused, was it intentional, or was just by mistake it happened? So causation implies that physician's action resulted in any alleged harm. What was that the physician did wrong that led to this harm? That is causation. So causation is also a national standard. Okay, which completely monitors or it decodes what exactly the physician was doing, what exactly the physician was supposed to do. Okay, so that is causation. So these three are the main legal procedures which is followed in medical negligence. So emergency patient care, this is also a part where a lot of cases arise. So by law, doctors are not supposed to refuse any emergency treatment. Okay, emergency treatment should not be refused by doctors on the pretext of caste, creed, ability to pay, etc. Okay, because saving the human life is of paramount importance in a medical practice. Even in hospitals, nursing homes, clinics of doctors, okay, who have declared that emergency services are provided in their institution, they are legally bound to attend all medical emergency cases. Okay, like accidents, injuries, poisoning. Okay, they cannot refuse treatment in such cases at any cost. Even when it comes to government hospital, public hospitals do provide emergency care, and they have to, the medical officers and doctors who are appointed by state or central government in these government hospitals, they have to provide emergency care. Okay, if the public hospital or the government hospital is not able to provide emergency care, then the compensation of that particular case is paid by the government, because the government is liable to make sure these public health hospitals, government hospitals, are well equipped for all types of critical care practices. Okay, if the government hospitals, public hospitals are not well equipped with critical care equipments, machineries, okay, faculties, it means that the government has to pay the compensation for any lapses that has taken place. Okay, so this is about the emergency patient care law. Few steps which you can follow to minimize the medical legal liability in ICU. Be up to date on national recommendations, okay, on various clinical conditions, and whatever care is being practiced, is it consistent with other hospitals, or is it consistent with the local practice, national practice? So stay up to date. Okay, whatever is happening new, or whatever changes or shift has taken place in the national standard, make sure you practice that as well. Any ambiguity or discrepant notations should be of focus. If the doctor is not sure about what exactly has to be done, there is a case of uncertainty in making a decision, okay, or uncertainty about recommendation, they have to hold back from any decision. They should not jump into taking decision. They should read properly, equip themselves with knowledge properly in that particular area, and only then go for a decision making. Okay, don't make any hasty decision if you are in a confused state. If a physician is in a confused state, if the physician is not sure exactly of what has to be done, what are the guidelines or recommendations, they have to study it first, research it first, understand, and only then take the decision. Documentation is very important. Any lapse in documentation could also lead to medical legal liability. So make documentations a key focus, specifically in critical care areas. Keep an open and honest communication with the patient as well as the patient party. Okay, and if at all some mistake has happened, before the patient party coming to know it from a third opinion or from other doctors, it is better to confess what mistake has happened. Okay, that good confession can also prevent certain trials to an extent. Okay, depends on how the family is taking your confession and what kind of gross confession are you making. Okay, so depending on these factors, uh, but usually confessing the mistakes before it has been known to the patient party that it was a doctor's mistake, before they find out, if you confess the mistake, there are high chances that it will not be tried or case will not be filed. Okay, we have a false claims act. It means it usually revolves around billing of services, falsification of billing to government for services provided by the hospital, or billing or putting the bill of certain services which was not, or procedures which were not at all performed on the patient, but still you have added these procedures into the billing, or these services into the billing of the patient, just to take money from them. These all things can lead to uh, court cases, medical liabilities. Okay, so false claim act makes sure it makes sure that billing of services is done adequately and appropriately, and there is no falsification of billing. Okay, there is no extra items added into the billing of the patient which was not given, or service was not performed. That is falsification of false claims act. Then certain potential risk of medication errors in ICU, as I have mentioned earlier, most of the medico-legal liability in ICU, it arises from medication errors. Okay, so from the patient, what are the potential risks? If the patient has a very severe kind of chronic illness, okay, any organ failure, in the high intensity of care, the patient is completely in the hands of the nurses or the physicians, comatose patients, etc. Patients they who require sedation, or patients who require mechanical ventilation. In these cases, there are high risk of medication errors taking place. Providers, if the medical service providers, doctors, nurses, physiotherapists, paramedics, if they are inexperienced, underskilled, they do not have proper knowledge of medications, okay, they are not in a psychologically well state, they are depressed, or they are going to under severe stress, they are suffering from some undiagnosed mental health issues. Okay, so, and sleep deprivation, if the providers are overworked, okay, they have a burden of duty on them, and if they are overworked, it could lead to medication errors. Then certain medications themselves, some cardiovascular medications, sedatives, analgesic medications, anticoagulant, anti-infective, usually high alert medications. ICU environment, the number of medications on average which the ICU patient requires is around 15 medications in 24 hours. Okay, it is an average. And usually when 15 medications or drugs are given, there are high chances of any adverse drug reaction taking place. Okay, the frequent changes in the substances and doses when a patient is under ICU, usually on a daily basis there is a certain change in the amount of dosage and frequency of medication given, because they are under constant critical care. Constantly they are being monitored, so doctor makes immediate changes in their frequency and doses, and if it is not followed up thoroughly by the nurses, that could lead to medication errors. Type of ICU risk, okay, large number of complexity of interventions, too many organ failures, okay, multiple organ failures, so multiple interventions can lead to complexity of the case, which can lead to medication errors. Lack of communication, use of new technologies in treatment which you are not completely aware of, failure to start recognized beneficial therapies, delay in treatment or delay in the correct treatment, correct mode of treatment. You started with the wrong treatment, later you realize the approach was wrong, then you make a shift. Okay, so these are the effects of ICU environmental medication errors. The organization has to make sure that the patient to nurse ratio, nurse patient ratio, doctor patient ratio, these are maintained in the ICU, and increasing the risk of errors above 1.3 to 2 patients per nurse. If the nurse is assigned more than 2 patients, or if one nurse is assigned 1.5 to 2 patients, okay, if that's a ratio, with increasing patient burden on the nurses, there are high chances of medication errors. Difficulty in working conditions, unscheduled hours, underworked, underpaid, okay, no supervision at all, premature and nighttime ICU discharges, okay, LAMA cases, leave against medical advice cases. Okay, in these all areas, there are high risk of medication errors. So coming to how to prevent medication errors, physicians should be aware of the risk factors of every medication. They should have a proper and thorough pharmacological education as well. Prescribing vigilance among the physicians caring for patients with renal or liver failure in these areas, specifically in these two organ failure conditions. You have to be very vigilant on what exactly are you prescribing, because these kidney failures, kidney as an organ, liver as an organ is supposed to detoxify the body. Okay, so whatever drugs you are putting in, it has to undergo detoxification in these two organs. So whatever medications you are putting your patients into, if they're suffering from renal failures or liver failures, you have to be very extra vigilant with this. Good handover technique, okay, these can prevent medication errors. For nurses, again, awareness of risk factors of every medication, properly educate yourself based on pharmacology. You have to second check when you are ready with the medication before you go and approach the patient to take the medication. Always double check, are you giving the right medication to the right patient? Is it the right frequency, dose, route, etc.? Double check it. Good handover technique again in nurses. Pharmacist, medication reconciliation, satellite pharmacy means being connected with other pharmacies as well. Support of the dose adjustment for patients with renal and liver failure from the pharmacy itself when you are sending dose adjusted medication. Okay, not relying upon the nurses to make the adjustment, but from pharmacy itself when you are sending a particular drug for renal failure and liver failure cases, you dose adjust the medication and send it from the pharmacy. It can prevent medication errors. Unit directors, every floor has unit directors, so elimination of extended physician work schedules. Make sure your physicians and nurses are getting proper rest. Computerization of physician order entry, so that reading the handwriting, illegible handwriting, etc. is not an issue. Clinical decision support systems, computerized intravenous devices, pharmacist participation in rounds. Pharmacists should also be a part of the hospital round that the doctors do. Protocols should be followed. Screening programs for psychological distress for the pharmacist, nurses, doctors as well. Barcode technology. New staff orientation. Give time for the new staff to learn their way around. Don't put them into tasks from day one. Intensivist staffing, adequate working condition, and caregiver fidelity. Okay, so these all orders you can follow. Organization, the entire hospital should adopt a culture of patient safety. Patient safety, which again is an international patient safety goal. Okay, so when you follow your protocols for patients of safety, your protocols are designed for patient safety, automatically the number of medication errors will decrease. Then vicarious liability in critical care. If as a doctor or as an intensivist, you should be aware of how well skilled or well equipped are the fellow doctors, juniors or resident doctors in handing over the case. Okay, if the intensivist is not present, whom are you leaving your patients with? Okay, are they capable enough? Are they responsible enough for your duty being dedicated to them? When you delegate a responsibility to the juniors or residents, you should make sure that these people are capable for handling such cases. Okay, if at all you delegate your duty to incapable juniors or residents, it could lead to medical legal issues. Telephonic advice to resident in ICU. Telephonic advices are dangerous, but in certain emergency cases, when nothing else could be done, telephonic advice has to be given. So when you should always ask your resident to take down written notes. Don't give oral advice. Okay, you can speak, but let them allow them to write it down carefully. And after they have written it down, you have to ask the residents to speak it out. Okay, to read it out back to you. And once they read it out, whatever is missing, you can add more. But always make sure that these things are done during telephonic advice. It has to be written down. One person should say, the other person who is receiving the information should make sure that they're writing it down. And at the end of the conversation, whatever they have written down, it has to be put out orally. It has to be read out. Instructions has to be read out just to confirm the guidances. Otherwise, if any harm has been caused to the patient based on this telephonic advice, it could lead to negligence as well. Research on medical legal standing. If any some critical care departments of the hospitals are areas where a lot of medical researches also can be carried out. If your institution is doing some medical researches in critical care departments or ICUs, you have to make sure that there is a conflict. There is a policy that removes any conflict of interest, because conflict of interest can arise from various areas. People who are funding your research, the institution that is conducting the research, the doctor, he or she who is conducting the research, they all may have certain conflict of interest. Okay, they may be supporting internally, they may be supporting or vouching for a treatment to work out, and they may try to play around with the readings or reports. Okay, just to make sure that it proves that their treatment is working out. Okay, so that is the medical legal standing. You have to make sure that all the conflict of interest are removed from the research. The investigators have been informed about the conflict of interest, who all are funding the research. Okay, if they have a conflict of interest, that has to be eliminated, reduced. Okay, or it has to be managed. Whatever conflict of interest is there from whichever source, it has to be managed, reduced or eliminated, because it should not affect the results in the research. Informed consent. All the physicians have an obligation to take the informed consent based on medical decision making authority with their patients, or whoever is a caregiver of the patient in context of ICU. So it has its own ethical and legal implications as well. There are two broad aspects of intensive care practice when it comes to consent. Okay, the first is invasive procedure, and the second is participation in research. Whenever an invasive procedure is going to be done, for example, putting the patient on ventilation, okay, consent has to be taken from the caregiver. If the patient is awake, and if the patient wants to take part in a research, you can take the consent of the participant or the patient here. Otherwise, if the patient is not awake or patient is incapable of giving a consent, caregiver's consent can be taken to help the patient participate in any research. So these are the two main areas where informed consent applies in ICU: whenever there is an invasive procedure. Second is whenever there is a participation required in a research work. For routine everyday procedures in critically care ill patients, it is assumed or presumed consent. It is not informed consent. General consent is taken here. In case and discharge against medical advice, DAMA, discharge against medical advice. All patients or patient attendants, they have the right, all have the right to refuse further medical care. Okay, they can leave the ICU, or the patient party can make a decision to leave the institution's ICU or to go to some other institution. Okay, they have the right to obtain all the details of investigation done, treatment that was given. Okay, but before sending the patient for any discharge against medical advice, the physician should make sure that they should talk to the patient or the patient relatives, attendants, regarding the exact condition what the patient is in, what could be the risk of shifting the patient right now. Okay, and all these things that we have discussed or right now regarding the patient's condition, it has to be documented as well in the sheet properly. Okay, and signature of the patient or the patient attendant should also be taken before they leave the hospital. Then death certificate in broad death cases. It's not uncommon in emergency rooms. Usually, or you will get a lot of broad death cases. So patient will be broad dead, and the attendants will be forcing the doctor to give some death certificate. So routine death certificate is issued only by the regional medical practitioner who has attended the last stages of the patient's life. But if the patient was brought dead to the hospital and dies unattended, or death certificate cannot in such cases, death certificate cannot be issued, because only after post-mortem a death certificate can be issued. Under no forceful pretext of the family members, death certificate should be issued to broad dead cases. Okay, broad death cases will get the death certificate only after a post-mortem is conducted. In case of any unnatural deaths, okay, on under anesthesia or in the operation theater, they should also always be reported to the police authorities. Okay, and if post-mortem has to be conducted, request for post-mortem should be put in as well. Post-death diagnostic procedure, even after death of the patient, if any procedure has to be done, it has to be done under the consent of the parents or relatives of the patient. Okay, doctors has to explain them how does this post-death diagnostic test help them in verifying the death of the patient or verifying any other situation or proving any other situation. So senior doctors should also always encourage the junior doctors to practice procedures in dead or dying patients like endotracheal intubation, etc. So for this also, you have to take the consent from the patient party. So that's about medico-legal issues in critical care. If you have any queries, you can put it in the chat box.